How are you going about this space? Especially this is something that you covered with TiNivo-2 study. And since we have you here, if you don't mind touching on the study design here and important findings, what we saw at GU ASCO 2025 was also patient-reported outcomes. Your
Yeah,
thoughts here, sir?
it was Brad McGregor and Katie Beckerman that led both studies. So what we did, we've seen a lot of folks in the community or in academia saying that you should always keep the PD-1 on board. Let's keep the Nivo, let's keep the Pembro and circle. Is there a rationale preclinical for it? I'm sure I can find something. But is there any rationale to keep the antibody on, like some people keep bevacizumab, Herceptin, especially with the long half-life, etc.? So we designed two studies only in renal cell that informed the majority of solid tumor. Now, there is a small exception in a small randomized phase 2 in melanoma, which showed no OS, but the PFS benefit to rechallenge. But here, this is the second study after Contact 3, where we use the PD-1 inhibitor Nivolumab to rechallenge, and the backbone is tivozanib. Knowing in the combo that tivozanib dose is lower, and tivozanib and the TKI intensity is important in renal cell. I don't think that's the reason the study was negative. So in patients with metastatic RCC that experience disease progression up to 2 lines of therapy, one of them is a PD-1, PD-L1 inhibitor. They get TiNivo is the experimental here. Primary endpoint PFS, all the endpoint, everything was negative. We published this in the Lancet. It was a concomitant publication, totally negative. What was done here is the quality of life gave us an idea in some group analysis. I don't think they led to picking a population, a subpopulation that benefit from the combo. That's the message. Brad McGregor did very good analysis on tivozanib dosage across most of the studies. So this was very good.
Yeah, and again, throughout different disease sites, be it lung cancer, be it melanoma, and a lot of these studies have moved immunotherapy up and upper. We saw that with Niagara as well. So a lot of our patients are getting exposed to
Right.
immunotherapy with
So
early
what do you
disease.
do? This
Exactly.
is different.
Ab-
This is
Absolutely.
patient that experience disease progression while
While
they're
on
on the
treatment.
immune checkpoint. If you have a CR and you're free of disease, free of treatment for 2 years, and you re-challenge, that's different. If you
Absolutely.
have side effects after 2 doses and don't do any more immune checkpoint, you go to chemo to a different and then an immune checkpoint that is safe comes in, you want to re-challenge, that's different.
Absolutely.
Now, the interesting thing I have to say, it's a small subgroup. 1/3 of patient guys had a therapy in the middle. On Contact 3, the last therapy was a PD-1, PD-L1. Here, third of a patient got a TKI in the middle. The PD-1 was within 6 months, but they got a TKI. So imagine, you progress on Pembro-Axi, you get Cabo, you stay on Cabo 4 months, you experience progression, then you can go on the study because your Pembro was within 6 months. I believe it was 6 months.
Yep. Yep. And again, Tony, with so much happening in this space before I close, how are you positioning tivozanib and belzutifan at the time of progressive disease?
When you compare, you don't have them head to head, but
We
interesting
don't.
enough, when you look at similar, they have similar PFS, but the response rate is higher with Bell. And like you said, many of these drugs, this was an attempt also to move TiVo earlier, right? Second line. And it gave you a great data with TiVo as second line post IO. It was over 9 months. And when you look at Bell's second line, it's a small subgroup in LightSpark 005. It's also good. So all these drugs are moving earlier line, and Bell in specifically is moving second line. We finished that study. First line, that's LightSpark 12, adjuvant. So
Yep.
I think in a way, if you ask me that question, it will be hard to answer. The response rate, maybe the tolerability is better with Bell, but the PFS same. We can play around more with TiVo. We know how to manage TiVo. It's been older drug. I see some patient with a lot of lung issues. I'll be honest with you. A lot of them are anemic. Now, anemia we can manage. Lung issue, COPD, etc. You have to be careful. What I do is I sequence them. You can have responses to Bell in patient exposed with TiNivo. So the idea is I'm shifting the question, say they should be used sequentially. Which one, I don't know.
Absolutely.
Luckily, I have this patient actually recently where I picked Bell over TiNivo. Unbelievable side effects to all TKI, and the blood pressure shoots from 120 to 190 no matter what. But I want to avoid all TKI no matter what. They get Bell. I have another patient that's COPD on intermittent oxygen at night. Probably doesn't need it, but at night made him feel better. It's like, oh, that's an easy decision. Could I have done Bell full dose and watch the? Actually, I did TiNivo, but next time, if they progress, they just started a few weeks ago. I'm gonna watch full dose and watch the saturation very closely. So that's more option to patient. That's probably why patients are living longer with their disease.
These two studies continue to show that these agents are active after immunotherapy.
They're active, actually, many of the drugs, if used them earlier. But since we don't have a biomarker, we don't know which one we want to use earlier.
Absolutely.
So you end up sequencing the rule.
Yep.